the group that's called boomers, you know.
Yeah,
so when you get to be an old fart like me, you know, they just say, okay, boomer. But what do they say in India? What do you call it?
Yeah, sir, we are live. We are live.
We are live. Good evening, friends. Welcome to Indian Arthroscopy Society webinar today. We have a doyen in shoulder arthroplasty, Professor Edward G. McFarland from John Hopkins School of Medicine, US, is with us. I must thank Shreyash for organizing this. Shreyash, if you can just briefly introduce Professor to all of us, and then we go forward with the presentation.
Sure. So hello, everyone. And on behalf of the Indian Arthroscopy Society, I welcome you from behalf of the President, IPS Oberoi, the Secretary, Swarnendu, Samanta, and the Executive Committee to this webinar on reverse total shoulder arthroplasty. Where are we today? As you know, the reverse shoulder arthroplasty was introduced way back in 1987 for cuff tear arthropathies. And since then, it has undergone a significant revolution and is currently used in the treatment of a wide range of shoulder pathologies. And it can produce excellent results with significant improvements in pain and function. But as we all know, it is a technically demanding procedure, and hopefully to make it easy to understand and implement it in our practice, we have a very esteemed, world-renowned faculty, Professor Edward G. McFarland from the United States. Dr. McFarland is a professor of orthopedic surgery at the Johns Hopkins School of Medicine. He is the Wayne H. Lewis Professor of Orthopedics and Shoulder Surgery and serves as director of the Division of Shoulder Surgery. He performed his residency at the very reputed Mayo Clinic and subsequently fellowship in sports medicine at the Kerlan-Jobe Center in California. He then moved on to join the Johns Hopkins team as an assistant professor and has been a professor since 2005, so over 15 years. His areas of special interest include injuries to the shoulder, elbow, and related issues such as shoulder instability, shoulder rotator cuff problems, and shoulder joint replacement. He is also very much into research, and his research interests include aspects of ligament healing, biomechanics of throwing, and epidemiology of shoulder injuries. He is a member of numerous prestigious professional organizations and serves on the editorial board of 3 journals and is the past president of the Associate of Bone and Joint Surgeons. He's also authored and co-authored over 170 peer-reviewed articles, 20 book chapters, and 3 full books. And needless to say, has won several awards for his research and service. So it's indeed an honor and a privilege for the Indian Arthroscopy Society to have someone as experienced as you. Dr. McFarland, a warm welcome to you. And I would like you to please present your talk on reverse total shoulder arthroplasty. Where are we today?
Great, thank you. Can you hear me?
Yeah.
Perfect.
Excellent. Well, thanks for that nice introduction. You left out the part about my COVID beard. So I put it on to look more professorial. So I probably should shave it off. It makes me look older. So I like the other picture better, frankly. But all right, so I should share screen here. Yes.
Yes,
that
please.
is. Let's see, I think, is it this one? I'm demonstrating my lack of technical abilities. It's this one. This one. All right, good. Does that work there?
Yeah, we can see.
Perfect, yeah.
Excellent, perfect. Well, thank you very much. It's a real honor and pleasure to present to you all. And I started out as a sports medicine doctor, but in the early 90s, there really wasn't anybody at Hopkins doing shoulders. And it was sort of my favorite area of interest. And then I sort of morphed into a shoulder guy. So I'm in the Shoulder and Elbow Society and those sorts of things. And let's see.
Sharing. I think you're sharing that screen.
I'm sharing that screen.
Yeah. Stop screen. Stop share. Stop share.
There. How do I get that one over here?
Just share screen again.
So as I was saying earlier, old guys, you know, can't
This one.
fancy this. All right, how's that? Does everybody see that?
Yes, perfect.
Let me see if I can advance it now. Still doesn't want to advance. Stuck. So
You'll have to just press the arrow at the bottom left, please, to advance it on the screen.
I don't have an arrow.
You just double click. I am Dr. Samanta. You just double click on the first slide, then you go with your, yeah, even you can go with your, this monitor, yeah, this thing, your mouse or else, yeah.
There we go.
Yeah, how it is done, yeah.
All right. So anyway, I'm fortunate here that we have international research fellows who come for a year. And we've had several guys from India, which and they all have done extraordinary work, and you probably or may know some of them, since it's a sort of a small, orthopedics is sort of a small community, but we've had a lot of great times with all of our fellows, and it's again a real honor to speak, and hopefully maybe one or two of them are listening. I also want to recognize my current fellow, Prashant, who without his help, I wouldn't probably be giving this today, not only helping me put videos in this talk, but also helping me with technical difficulties this morning. And anyway, so he's going to be finished here in the spring, might be looking for a job. So I'm going to give him my highest recommendation. He's done a fantastic job. And you can see the Hopkins dome there on the other side. So just for anybody who hasn't been to Baltimore, here's, we're over in the eastern part of the United States, of course, and we're not far from Washington, D.C., about 30 miles. And here's, we're on the Chesapeake Bay. So can you see my mouse there?
Yeah, mouse is visible. Yeah.
Mouse is working.
Yeah.
Well, anyway, so Chesapeake Bay is a large water area on the eastern part of the United States, and we're sort of nestled way back up in here, and Washington, D.C. is right here. So we're only about 35 miles from Washington, D.C., just so to get you oriented a little bit. Johns Hopkins is a large institution. We have somewhere around 3,000 or 4,000 doctors, and oddly enough, we have only around 1,000 beds. So with the COVID thing, it's been a challenge to take care of everybody, but this is sort of, there's a main campus over here, and this is the older part of the hospital and original part of the hospital. And this is the new hospital, the one that was built and finished only 2 or 3 years ago. So things are still expanding and growing here, lots of research, et cetera. So these are my disclosures. When when reverses first came out in the United States, I started out doing a DePuy and then also did some Tourniers, then did a few globals, and now I do a Stryker. So it's been a transition of different types, and things as types of implants have changed. I still get some corporate support for our fellows from these different groups. So the plan today is to talk a little bit about arthroplasty in general, and talk about why you would want to do a reverse. I'm going to concentrate a lot on surgical technique and tips, because I think that's sort of the nuts and bolts of this thing. A few precautions and a couple cases at the end, and there'll be plenty of time for discussion. So why are we going to do any shoulder arthroplasty? The main reason to do it is for pain. You know, patients come, they have night pain, they have pain at rest, pain with activity. They also lose function, you know, so for patients, it's not just a pain thing, but it's a function thing. Usually they've failed all the non-operative things. They failed cortisone shots, and they can't be active, and they're pretty miserable. So actually, the more pain they have, the better off they'll be, and with the results in terms of satisfaction. So again, arthroplasty is first a pain relieving operation. And the reason that's important is that some of these patients that have cuff tear arthropathy, particularly, they may not get massive improvement in their motion, but they'll at least have pain-free range of motion. So again, the main reason to do these operations is pain. Some patients have rotator cuff arthropathy and have no pain. And so just operating on it for function alone, you're sort of a little bit of a slippery slope, as we say. So if you don't do the operation for pain, this is sort of what you want right here is the happy patient. I don't promise patients full range of motion. I tell them the goal of a reverse is to reach the top of their head without pain. And usually if they have modest expectations and they do better than that, you look like a hero as opposed to looking like a chump. So as we all know, hemiarthroplasty went all the way back in 1955 by Dr. Neer, and it was used for pretty much every shoulder condition initially because total shoulder wasn't even invented. And so it would be used for arthritis or fractures, failed internal fixation, etc. And the hemiarthroplasty these days, though, is used primarily for fractures. It's also used sometimes for avascular necrosis. Can be used for cuff tear arthropathy in some given patients, and also oftentimes is used in younger patients where you don't want to resurface the glenoid side. But this is a typical result in the patients who'd had a hemiarthroplasty for a fracture. Even though fractures can be treated with internal fixation or hemiarthroplasty, they sometimes don't get excessive range of motion. But again, if you do it for pain, they're usually pretty happy. So in terms of the indications for fractures, the reason to do a hemiarthroplasty is the fracture configuration is not compatible for internal fixation like the one on the left. If there's a head split, of course, hemiarthroplasty is usually indicated over internal fixation, and very comminuted 3- and 4-part fractures are also considered an indication for a hemiarthroplasty. The reason that's important is many of these indications have now sort of become more acceptable to do a reverse as opposed to trying to ORF or do a hemiarthroplasty. So the trouble with hemiarthroplasty for fractures, though, even though they can give patients pretty good pain relief, usually the patients, or not usually, but oftentimes they'll complain of, it doesn't hurt until I move it, which is not optimum, or they have pain that starts to wake them up at night, etc. So the trouble with hemiarthroplasties is that the tuberosities sometimes don't stay where you put them, and they tend to rotate away, and then the patient gets weak. The other thing you can get is tuberosity resorption like this. It's not really clear why that happens, but it does happen a fairly large percentage. And they also, even if they do have the tuberosity attached, the rotator cuff doesn't seem to work. So they can also get superior wear of the glenoid like seen here, that over time that can be a problem. And so this results in pain and loss of motion. And so hemiarthroplasty sometimes for fractures is just not as successful or predictable as we would like. So in those patients that lose range of motion, though, the reason they lose it is because they get superior subluxation, like you see here, or they get superior glenoid wear is another reason. And the third reason that's really probably one of the more prevalent things is that they get rotator cuff dysfunction. So even though maybe the tuberosity heals in the right spot, they still don't have a functioning rotator cuff. So hemiarthroplasty for fractures is a little bit unpredictable. One of the major causes of dissatisfaction with a hemiarthroplasty for a fracture is that they get superior subluxation or escape. So you can see here the tuberosities essentially are gone. And it's really important when you do fracture work, though, if you're going to put a hemi in, that you save the tuberosities. There for a while, people, for some reason, were excising the bone and sewing the tendons down. I think bone to bone healing is much better. But if you do tend to see this sometimes in people who have massive rotator cuff tears, they get this superior subluxation like this, so that the humeral head starts to, this is somewhat of an extreme example. This is what it looks like. The patient goes to raise their arm, and it almost looks like the humeral head is sort of squeezing out the top of their shoulder. And as a result, they can't really raise their arm. So the other thing that will cause this is if you do a massive rotator cuff repair and it fails, don't ever release the coracoacromial ligament, because all that does is prevent restraint, or you lose the restraint to superior subluxation like this. So you see this oftentimes in patients who've had rotator cuff repairs. They can't raise their arm because they have this superior subluxation type pattern. And what that looks like sort of diagrammatically is when your arm is, when the humeral head is reduced in the glenoid, there's the forces of the rotator cuff keep the head centered so that when the deltoid fires, it actually lifts your arm. The trouble is when you lose the cuff, the head superior subluxes and the vector changes so that when you fire your deltoid, you can't really lift the arm. It pulls the humeral head this direction. And as a result, the patient loses motion, or if they can still elevate, it's oftentimes very painful. So this superior escape pattern is made worse by releasing the coracoacromial ligament, but it also happens if you tear just enough of your rotator cuff, your shoulder just doesn't work. So in cuff tear arthropathy, so in patients who've had long-standing rotator cuff deficiency, they get this subluxation like this, where the center of the head is no longer in the center of the socket. And as a result, the upper half of the glenoid starts to wear. And then also you eventually get wear of the greater tuberosity hitting up against the acromion. And so that can take patient, it's almost unbelievable they let it get this bad. But again, you can see that there's wear the superior half of the glenoid. There's really no space here where the cuff should be, and the acromion has actually been essentially totally reformed. So this is called acetabolization of the shoulder. The other thing that's very characteristic of this is these patients, their greater tuberosity just eventually gets worn down, so that the humeral head, we call it an ice cream cone deformity. The humeral head gets round, almost completely round. And this is important later because when you go to cut the humeral head off, there's really no landmarks for where to make the appropriate cut because the tuberosity is gone. So this is sort of end stage rotator cuff tear arthropathy, which is what one of the areas that the reverses have really revolutionized how we treat shoulders. So just a couple things about rotator cuffs though that most people probably or maybe don't know, but the rotator cuff function actually is not so much to rotate the shoulder, but to compress the shoulder into the socket like this. And so if your subscapularis and your infraspinatus are intact, or if you have at least your external rotators, you can oftentimes have enough compression that you can elevate your arm, and it prevents superior subluxation. So you can actually have a completely torn rotator cuff and have full range of motion. So this gentleman has no supraspinatus or infraspinatus, and he has got great range of motion. He has very little pain. And so this is not the patient that needs a reverse arthroplasty or probably any kind of operation, because he's very happy and he can move his shoulder. The other thing is shoulders like this aren't doomed necessarily to have arthritis. So I get a lot of patients sent to me who don't have much pain and they have weakness and maybe loss of function. And people say, oh, they've been sent to me for a reverse. And so doing a reverse in this population is for range of motion alone is a little, you can do that and have a good result, but it's generally not as predictable as pain relief. So shown on this side over here, this is called an external rotation lag sign, where the patient's missing their external rotators. And if you put the arm in external rotation and then let go, they can't hold the arm in that position. So they basically, that kind of patient's going to have trouble reaching their mouth and the top of their head unless you do something like a tendon transfer. We can maybe discuss that later. It's kind of the advanced course. But again, people who have this external rotation lag, you have to be very careful. And on the other side, you can see the guy's got a nice little pacemaker there. He has a sort of classic superior escape in that his humeral head gets sort of stuck up underneath his acromion. But if he takes his arm, he actually has full, decent range of motion. So this guy doesn't have any pain. He can really use his arm. And this is called pseudo-paralysis. He's not the kind of guy that probably would benefit from a reverse total shoulder arthroplasty. So like anything, it's some things are good for some indications and not others. So you have to be very careful in your patient selection, particularly if you're going to start doing these. The best patients are those that have pain, because you'll end up being a hero and not a chump. So the indications again are range of motion, but the one thing you do have to have is you have to have an intact deltoid. If you're missing your deltoid, like over here, and you're missing your rotator cuff, then you really can't elevate your arm. So again, it's important that they have an intact deltoid muscle. It's also important that you take good care of the deltoid muscle when you do the surgery, because once the rotator cuff is gone, they can have full elevation because they have a deltoid. But if you lose your deltoid and you have no cuff, then you're essentially doomed to not have good range of motion. So the next thing, of course, was the total shoulder arthroplasty, and they NEAR came up with adding the glenoid component. And most people got excellent results in pain relief, and they could increase their motion, as we all know. So there is still a place for total shoulder arthroplasty. The indications have been pretty well listed these days. They do it primarily for osteoarthritis, like shown here, some immunologic arthritides. You have to, though, have a relatively normal glenoid, whether you use a pegged or, this is an older picture, keeled. And you have to have an intact rotator cuff for a total shoulder arthroplasty. And you also have to have normal humeral anatomy. In other words, trying to do a total shoulder in somebody who has a malunited proximal humerus fracture is probably not a good idea, because they almost never have normal rotator cuff function. So the indications for total shoulder arthroplasty have largely narrowed now to patients who have an intact rotator cuff and have good glenoid bone. And so this is what happens when the rotator cuff fails in somebody with a total shoulder. They again get this superior escape like this. The humeral head doesn't articulate with the glenoid anymore, and they sort of have the same kind of issues as a cuff tear arthropathy patient. So patients who have don't have intact rotator cuffs should probably not get a total shoulder arthroplasty, and probably should go on to a reverse. So the contraindications for any arthroplasty basically are ongoing infection anywhere, paralysis, such as say after a stroke or from a cervical spine injury, neuropathic joints, Parkinson's disease. The trouble with Parkinson's is that they shake a lot, and they can shake the implants loose. Glenoid bone loss I mentioned, and also rotator cuff tears. So the indications for total shoulder have become fairly narrow. So as mentioned earlier, reverse total shoulder arthroplasty became very popular in Europe around the 1990s, and was successful in Europe. It wasn't approved in the United States until 2004. And the FDA, our regulatory body, approved it only for cuff tear arthropathy. And that's not really, nobody really pays attention to that anymore, because the indications have expanded to a lot of other things. But probably the patient population that they work the best in, that really are very happy, are the cuff tear arthropathies. So they're really basically, in the 2000s, there were two types of reverse total shoulder arthroplasty. The first was the Grammont type system, shown on the left, and it had a sort of what's called a medialized glenoid. In other words, you just ream the glenoid flat. The center of rotation actually becomes more medial, and that's why it's called a medialized component. And the head neck angle was 155 degrees. Frankel, though, felt that if you put the glenoid too medial, you get impingement down here. So he came up with the idea to sort of lateralize the center of rotation a little bit, so you can see the sphere is much larger. And also the head neck angle was 135. So this one, these two were sort of competing models through the 2000s and early 2010s, while we sort of figured out which ones had the best results. Since then, though, there are probably 30 or 35 systems, and they all vary according to different ways of configurations of the glenoids or whatever. So when you do go to start doing these, you kind of have to pay attention to some of the geometries. The good news is most of them work pretty well. So the Grammont type is sort of called medialized. The Frankel type is lateralized. The base plates can be pegged, or they can have a central screw, or they can have both. The head neck angles now are available 135, 145, or 155. 135s tend to have less impingement and instability. You can have the humeral tray, which is this portion with the polyethylene on it. Base plates can be pegged, or they can. So they can. I'm getting reverberation for some reason. Anyway, the tray is either settled down inside the proximal humerus, or it sticks out a little bit. That's called an onlay. And then you can have any size of varieties of stem lengths. So there's lots of options, but whichever system you use, try to get familiar with it. So as far as surgical approach, there are basically two surgical approaches. One is the superior approach, which was used in Europe there for a while. And not too many people use this anymore because it involves splitting the acromion. So you have to worry about acromial non-union. And probably the approach that most people use, at least in the States, and I think most shoulder surgeons, is a deltopectoral approach. And this, of course, is the main approach to the shoulder, and it's the most extensile. And it's the good thing about it is you can use it for everything, whether it's a primary arthroplasty, you can use it for shoulder stabilizations if you wish. And you also, it gives you great exposure, which you really need for revision cases. It's also such that you can expand it if you need to. So when the whole thing though starts with positioning the patient. We use a sort of modified beach chair without a headrest, and we just bring the patient to the side of the table. And can't get my video to work here, but anyway, so you want to make sure that you can clear the table. So the arm, when you bring it down like this, you have to be able to get instruments down the center of the humeral shaft like this. So you have to make sure before you secure the patient to the bed that you can actually get down the shaft here. So that's the only thing I would say really critically. Other is you have to have the head in neutral, because one of the more common complications of this, unfortunately, is a brachial plexopathy. In this position, the brachial plexus is getting stretched from here to here, and you have to be very careful during the case to make sure that you don't leave the arm in that position a lot of times. So the incision, I usually start at the inferior margin of the clavicle and come all the way down to the deltoid insertion. You need to make the incision as long as you need to make it. There's no sense trying to do this through a small hole. And particularly if you're starting out, the larger the incision helps you get orientation of the anatomy and those sort of things. The other reason to do it is part of the operation, you have to get the deltoid over the proximal humerus. So if you can sort of release up above to the coracoid, that's the best. It gives you a lot more, the deltoid becomes more mobile and you can get it over the back. You want to localize the cephalic vein, and I like to stay right on the vein. Some people just cut right through the muscle and it just makes a big bloody mess. And you want to make sure you find the coracoid. Mattson called it the lighthouse of the shoulder. And if you're real careful like this and protect the axillary nerve, the interval will oftentimes just sort of easily open up for you. And I'm sure some of you have done some brachial plexus work, but if you're careful here, it also decreases bleeding, which is very helpful. So there's all sorts of controversy, you know. The main, seems like every time you do this approach, everybody wants to know you take the vein medial or lateral. I don't think it matters at all. I personally prefer to take it lateral, but here we are just releasing the fascia over the vein so that you can get down into the interval. So you want to develop the internervous plane. Again, here we are finding there's the vein there. I'm going to take it lateral, but you want to find the coracoid. And the key thing is don't go past the coracoid, because if you go past the coracoid, the next thing you're going to find is the brachial plexus. Also, if you go above the coracoid, you have to be careful up there as well, because the plexus gets a little more superficial. And lastly, you don't want to rip the vein up underneath the clavicle where there's subclavian. That gets to be a little bit of a mess. So at this point, the goal though is to identify the clavipectoral fascia and find the conjoint tendon and the coracoid. So sometimes there's adhesions. There's also these little bleeders up proximally that you can get. They're just sort of an aggravation, not really all that important. The one thing that is an aggravation as well is there's an ascending branch that goes up and down the humeral shaft, and it tends to be a little bit of a bleeder. It connects with the anterior circumflexes, so it's real nice to get good hemostasis so that they don't bleed too much. So now here we are, we found the conjoint tendon, which is seen here, and this is the coracoid. We want to develop the interval between the subscapularis and the conjoint. There's a small little muscular bit of the conjoint right here that if you cut right down on the conjoint, all it does is bleed. So you want to make sure that you develop this interval just a little lateral to the conjoint tendon. Then you can stick a retractor here. This retractor medially though is on the brachial plexus. So you don't want to pull on it. It's just you just want to make sure that it holds the interval open for you. And so this is the subscap, and then here's the coracoid and the conjoint tendon. So you develop that interval between the conjoint and the subscapularis. If you need more room and you're having any trouble seeing, it doesn't really hurt to release some of the upper portion of the pectoralis insertion. You just have to be careful because where it inserts, the biceps tendon is right underneath of it. So I usually tenodece the biceps tendon as opposed to a tenotomy. If you were to get the biceps tendon down here, it's not the end of the world. You can just do a tenotomy, but I try to take it and protect it. The other thing that helps is to, once you get this interval between the deltoid and the shaft, is to release some of the deltoid insertion distally with your finger. And what that does is allows the deltoid to come back over the top of the humerus like this and gets it out of the way. And it also prevents you from tearing the deltoid from just pulling on it. So those are all little tricks for exposure. There are some concerns. Obviously, you want to know where the brachial plexus is and the axillary artery, et cetera. We did a study a long time ago in cadavers. We just put a pin in the glenoid rim and measured the distance to the plexus. And as you can imagine, this is sort of a axial type view. This is the glenoid from the glenoid rim to the brachial plexus is about 2 centimeters. And it's really that 2 centimeters, the reason it's 2 centimeters is that's about the thickness of the subscapularis. And the reason that's important is in some patients who have cuff tear arthropathy, they have no subscapularis. So the only thing between you and the brachial plexus is the capsule. So you have to make sure, you know, the old axiom about getting on bone and staying there, it's really quite important. And if someone doesn't have a subscapularis, you have to be very careful when you get into the joint that you don't put a lot of retractors out in this area. And if you do, they need to be on bone. So you have to be very cognizant that the plexus is sometimes closer than usual. The other thing too, as I mentioned, is don't go through the, here's the pec minor. You want to make sure that you don't come lateral to the conjoint tendon because you'll end up in the plexus. So you don't end up in this area, and you also don't want to get it up in this area up here. The other thing you have to be concerned about a little bit is the axillary nerve. It's actually inferior to the subscapularis. I personally do not expose the axillary nerve because I've got enough to worry about, and it's probably best to leave it alone anyway. Usually you ligate the anterior circumflex vessels, and you can feel the nerve down here if you wish, but it's not absolutely necessary. Some authors have talked about doing what's called a tug test, where you pull on the nerve and you can see it as it comes around the proximal humerus, and you can sort of see it on the underside of the deltoid. This is what a tug test looks like. You sort of pull on the nerve down here and you feel it back over here. I've not really found that to be necessary. Of our 870 cases, I've never used a tug test, and we only had 6 cases of axillary nerve neuropraxia. So I don't think you have to necessarily go looking for the nerve or feeling the nerve, but you just have to know that it's down inferiorly near the capsule. So the next thing you want to do is to find the subscapularis. So again, here's the conjoined tendon. This is lateral, this is medial. You have three options for the subscapularis tendon, but here's the anterior circumflexes. I usually ligate those and pull the deltoid out of the way so you can see the insertion of the subscap, and then the biceps tendon is going to be a little more lateral. So your three options are: number one, to release the subscapularis with the capsule, which is what I like to do. It's very easy and allows you pretty good exposure. The second is you can release the subscap like a Bankart, and I'll show you an example. And then the third is a lesser tuberosity osteotomy. So the good thing about peeling it off like this is you can peel it off enough that you can get in the joint and put a retractor there. This retractor, so here's lateral, here's medial, this is under the deltoid, this is between the conjoint and the subscap. And so you can just peel the subscap right off the lesser tuberosity, and you can start up higher and work your way down onto the head neck angle or shaft down here. And it's pretty straightforward. This retractor can also put tension on the subscap so that you can just gradually peel it off like this. The key though is to stay on bone. And then we like to, once we're done with that, I like to tag it with a suture so you can find it later. And if necessary, put it back. But this is what it sort of looks like. You can come down onto the head neck junction here, and you want to release directly on bone. Oftentimes there's some large osteophytes here. I tend not to use sharp retractors. I tend to use smooth Homan retractors down here, because the axillary nerve and the vessels are all down that way. And so you want to try to avoid using sharp retractors down in this area where you might find the nerves. Second option is to do a standard Bankart kind of approach, where you actually release the tendon and leave a tendinous portion on, leave some tendon on the humerus and some tendon on the subscapularis. I didn't think people use this much anymore, because the trouble is sewing back down just to the tendon is kind of meager. But I did do a narration of a case done by Joaquin at Mayo, and he still actually does this, but even when he does it, he makes sure that he secures this lateral portion, he secures it in some fashion to bone as well. So tendon to tendon repairs like this tend not to be so successful. The other is a lesser tuberosity. It has the advantage maybe of a little early healing. It does make the procedure a little more complicated. You have to worry about, once you've made your head cut, or once you make a head cut, that this breaks in here or something. There's a sort of questionable whether it's any benefit over a peel, but you probably don't have to do this unless you are worried about instability or something. So the next thing you're going to do is you're going to release the capsule at the head neck junction like this. You can see here's a better view of what you do when there's an osteophyte. You want to keep a retractor here, but if you stay on bone here like this and go along the medial aspect of the head neck junction, you can release the capsule pretty safely up underneath the osteophyte. I usually keep a little instrument down here to protect the axillary nerve. If nothing else, I use a pickup to do it, but a smooth retractor down here is also very helpful. So again, the axillary nerve is down here somewhere. So the next thing you're gonna do is tag the subscap like this. Then you want to release the rotator cuff interval. And what that does is loosens up the subscap and the structures in the front, the capsule in the front. So this is the subscap. This is actually, you can sort of see even a bit of the biceps tendon right here, right there. So the interval is basically right down the biceps tendon. And what that does is allows the deltoid now to also come back over the top. But you want to make sure that you release all the adhesions in the subacromial space if you can. It's a little harder in patients who've had previous rotator cuff repairs. So you have to be real careful how you handle the deltoid. So like I said earlier, if you they don't have a functioning rotator cuff and you mess up the deltoid, then they're not going to be probably very happy. So as far as making the humeral head cut, I do a little bit of legal work in the United States, and about the only time the artery ever gets cut, the axillary artery is right now. And so I always put a retractor inferiorly to protect the brachial plexus. I put something behind the humeral head, so if you do in fact go too deep, you're not going to get all the neurovascular structures. And one up here to protect the deltoid. And so the humeral head cut, I like to make sure that there's no chance I'm going to do something bad. Some people use a guide. There's usually systems that you can work with that they put a stem down and then they leave a guide. I usually just eyeball it, depending on how much deformity there is. But I usually mark it at least with cautery so I know. I also like to cut it in 30 degrees of retroversion. It's kind of controversial, but the reason to do 30 degrees of retroversion is that if that should fail and they ever have to have a hemiarthroplasty, that's the amount of retroversion you want. So maybe you get a little more external rotation with 20 degrees. It probably doesn't matter a lot, but I don't think anybody's putting them in 10 degrees of retroversion anymore. I think 20 to 30 degrees is sort of the acceptable amount. So then we prep the humerus. The key thing when prepping the humerus is, if you notice, we bring the arm down into an adducted position down here, but when we're not working in the shaft, we take the tension off the brachial plexus. So this has helped us a lot prevent getting plexopathies. The other thing too that's real critical is this thing needs to be able to go straight down the shaft. If you put it in at an angle, I haven't seen this happen much anymore, but earlier in my practice, people would stick the prosthesis out the lateral side of the humerus. That's a bad thing. So you want to make sure that you can get a straight shot. And again, this has something to do with even positioning of the patient. And I don't usually, once I've done this, put any other flat protectors or anything. Usually I use the implant itself. So you're going to ream and then you're going to broach proximally and put the broach in. Again, some people use some sort of flat surface here to protect the proximal humerus, but they tend to fall off all the time. The other thing too is there are people that report fracturing the proximal humerus. And again, you just have to be gentle. A humerus is not a femur. And so a lot of times the fellows want to just hammer away. And if you do, that's when you're going to break the humerus. So I like to press fit the humerus distally. Again, it's just an individual preference. So the next thing you do is prepare the glenoid. This is probably the most challenging part. First thing you do is you take the biceps tendon out. I usually put a sharp Homan posteriorly, inferiorly, and then remove the biceps tendon up here. And then I punch a little hole in the capsule and put a smooth Homan up there. And what that does is get you a pretty good straight look at the remainder of the glenoid. Then we put a retractor anteriorly in the subscapularis recess, and we can then remove all the anterior capsule attachment on the glenoid and the labrum. So we remove the labrum circumferentially. I like to use a very sharp tip of Bovie as opposed to the standard Bovie. It's it cuts faster and it makes it easier to get the labrum out. So I usually put a 2-prong or some kind of retractor along the front, and we put a sponge on it so that we don't have to hold it. We can actually secure it out here somewhere. But anyway, so the goal is to essentially get retractors around the glenoid. So once you've exposed the glenoid, you can see now we see the anterior rim here, the labrum's all taken out. There's 3 or 4 different ways you can help expose the glenoid. The problem is the humerus gets in the way. And so one of the key things though is to release the capsule along the glenoid circumferentially. And that allows you to get the humerus out of the way, but you can stick a sharp Homan down there. And the reason you want exposure like this is first off, you want a straight shot at the glenoid. And the other is when you go to ream, you want to be able to ream without destroying the humerus or other things. So sharp Homan sometimes works. Whatever. The other thing you can use is a Fucata retractor. I personally don't like this very much because the tines are up against the glenoid and the reamers tend to hit these tines. So it's a little harder to use. Fortunately, this is the only plug I'm going to put in for anything is Stryker has this retractor that they designed that has sort of, these are off at an angle. So you can put this thing down in there like that. And when and oddly enough, it works. But one thing you have to do though is you have to make sure you have the stem and the humerus. It'll smush it or smash it. But see, it gives you really tremendous vision. But the advantage is that the reamers don't hit these tines because they keep it away from the glenoid rim. But anyway, so you can experiment with whatever you like to use. But these, there are special retractors that make it a little bit easier. The next thing you want to do is figure out where to put the glenoid component. We had a little custom plastic piece like this made. You can use the guides that they're provided by the company. You basically, where you put this is a little controversial. It used to be thought that you should put the sphere as far down on the glenoid as possible. I don't know that that's necessary so much. You want it close. Kind of depends on the system you use. The good thing about this is I can actually bovie through it. And I like to freehand the pin. There are obviously lots of different kinds of guides that you can use to do the same sort of thing. But it's, again, personal preference. So you want to figure out where you're going to put this thing. And then you ream. Most of the reamers, or most of the systems, I think, ream in a little bit of inferior inclination. So I like to freehand the pin, but somebody from the front has to make sure that it's only 10 degrees of inferior tilt. So basically these, you have to just be familiar with the system that you have and things like that. But again, you can see we've got really great exposure and we've got a straight shot onto the glenoid. So there is some indication that one thing you don't want to do, like in the total knees, the expression is don't create varus. Well, in reverses and total shoulders, the one thing you don't want is superior inclination, because what that does is it first off creates some rocking horse kind of phenomenon. And the other is that it increases the shear forces between the base plate and the glenoid. So you want the pin preferably in 10 degrees of inferior inclination. You don't really want it in neutral, but certainly you don't want it in superior inclination, which can happen particularly in cuff tear arthropathies where sometimes large portions of the superior glenoid are missing. So again, you have to be very familiar with the anatomy and know what you're doing. So when you do ream, again, you want to ream flat, and it sometimes helps to, you can get an idea how much bone you have left or gonna have left with computer modeling. I don't usually use models very much. I mean, I like to get a scapular model made, but you need to have a CT scan to see how much bone there is. But basically you want as much coverage as possible. These reamers are half moon reamers, which are really fantastic because they're easier to get in than the full reamers. So again, every system's different, but flat reamers are really, I mean, half moon reamers are really fantastic. Let's see if I can get this to go again. Anyway, you basically want to go down to a flat surface. The next thing you want to do is figure out where you want the holes in the system to land. Each system is a little different. This particular system has a central screw, which I prefer because once you put the central screw down, the base plate it ain't going anywhere. Then you want to use as many peripheral screws as possible. I think there are a couple systems that have only 2 peripheral screws, which amazingly they stay put and don't have large failure rates. So to each his own, but I personally like to use a prosthesis that has potentially 4 peripheral screws. And you want to use interlocking screws. Studies that had the highest base plate failures had non-locking peripheral screws. So you want locking peripheral screws. Many of these systems have a central peg. I'm not real fond of central pegs unless they have a screw that goes through them. But one thing I will say, sort of anecdotally, level 5 evidence, when you put these central screws in, or like say the Frankel system has, this is all monoblock. So you just put it in. The central screws, the fixation is just so fantastic. It blows your mind. So one thing you want to make sure of in this particular system, this is a striker system. It almost takes 2 people to get the last few threads in. You don't want to make, in any system though, when you're putting the central screw in or putting the implant in, you want to make sure you don't fracture the glenoid. That was a problem early on in the 2000s when we first started doing these. So again, you can't just hammer away. The glenoid is not an acetabulum. So then you can trial the sphere. You have to have different sizes, of course. And most of us feel like you want to use the largest size possible. But again, it depends a lot on the soft tissue tension and those kinds of things. I personally like to trial. Some people just go ahead and put the reel in. But I like to make sure there's enough much room. So once you get the trial in, you can trial the humeral side, and you reduce the shoulder. You want to put it through a range of motion and make sure that it doesn't gap open or sublux. You want to do a little tug test or tension test, just like you do in a total hip. Stick your fingers in there and just sort of pull on it. You should probably have just about a millimeter or so of laxity. If you can pull on it and dislocate it with your finger, it's too loose. So again, where these dislocate is with the arm and abduction and external rotation. So you know, put the arm in that position and make sure that it doesn't pop out. So then we put the real ones in and then reduce it. Again, we test the stability. Again, here's putting the humeral stem in up here. Here's putting in the real sphere and the real metaphyseal tray and testing the stability. So life is good. Whether you put the subscapularis back or not depends a lot on the design of the prosthesis. Back when I was doing a more Grammont type prosthesis, the dislocation rate was high, so I was fixing the subscapularis on everybody. Sometimes it just won't reach because it's deficient or it's gone. So the good news about reverses is you can actually live without the subscapularis. The current system I use with Stryker, because it's somewhat lateralized or has an onlay humeral component or metaphyseal component onlay tray, most of the time the subscapularis won't even reach. And I've not found that patients complain about that very much. And the good news is that with these components, the newer designs, instability is a little less common. So whether you put the subscap back or not is really almost a personal preference. As far as postoperative care, I let patients start moving their hands the next day so they can do finger, wrist, and elbow motion. We want them to use their lower extremity and their upper extremity as much as they can early on. So we let them use a computer within 2 to 3 days. We let them feed themselves within 3 to 5 days. We start pendulums right away. And all that's because the system is usually put in very snug. And the second is you don't have to, most of the time, worry about subscapularis failure like you do with a total shoulder arthroplasty. But even then, we let them start moving their finger, wrist, and elbow right away. And I don't send patients to physical therapy. They usually do things on their own. We have handouts that we give them when they come back at a week and then again at 6 weeks. And we don't really like them to do any strengthening or anything that might shake the screws out in the first 3 months. I always tell patients, you know, you got the rest of your life to get strong. Just sort of let this heal up and work on your range of motion. So we have all these sort of home instruction sheets and this kind of thing. In fact, if you go to our website and you're interested in using these kinds of things, take anything you want, they're all free. So again, they don't want to do anything that'll shake it loose. Have plenty of time to get strong. And I tell them the most important thing is range of motion. So the first 3 months, particularly, are range of motion, range of motion, range of motion. I don't usually let people play golf until about 6 or 8 months. Some people start earlier, 3 or 4 months. I think that's probably a little too early, but you know, there's really no good studies. So the good thing about reverse total shoulder arthroplasty is there's not only significant improvement in pain and range of motion, but also patient reported outcomes. Patients with reverses actually do quite well, and many of them are very satisfied. As far as survivorship, These are the studies that have been out in the past few years. Early on, the 10-year survival was around 91% with Walsh and things, and that has been maintained. 15, there's only one study with 15-year follow-up, and that was Gerber last year, and they had an 85% survival at 15 years. So in fact, I think it's, my personal feeling is it's probably going to be higher than this when we finally start getting some more longer term studies. So they're fairly durable, and part of it probably is because many of the patients are older and lower demand. The trouble with reverses, though, is that there were a bunch of complications early on. Instability, the early designs, the instability rate was 8 or 10%. And instability is a real pain because you have to reduce it. If it stays, it doesn't stay reduced, then you got to go in and put more parts in to tighten it up. Base plate loosening was kind of common. And this 10% was Frankel's early experience because he used a really lateralized sphere, and he changed that design. And so the dislocation rate, the base plate loosening rate with his type prosthesis now is around 1%, less than 1% at 5 to 10 years. Notching early on was a big problem. Scapular stress fractures were a big problem. Fortunately, in the current designs, instability is much less now, about 1%. Base plate loosening is about 1%. Notching, it's controversial whether notching is a problem or not long term. Obviously, you don't want to, the less you have, the better. Once the notching gets up to where it's below the screws or above the screws, that's a concern, obviously. But even then, sometimes they don't, even though they look like they're going to fall out, the patients don't have pain and it's not loose. Scapular fractures, it's kind of controversial in that some people say it's due to its type of the design of the prosthesis. It's probably multiple factors that cause these, but they can be really debilitating for patients, because what happens if you fracture your acromion or your scapula, then your deltoid doesn't have a good solid fixation, and patients can lose motion. So a couple of quick cases. This is a guy with cuff tear arthropathy. And again, he's got this classic superior subluxation look, you know, his arm only goes that far. If you have him pick his other arm up, you can get his arm up high. This is his AP radiograph here. It's a Grashi view, which I recommend to anybody doing shoulder surgery. And you can see that his glenoid is down here. The humeral head is way up there. He's got some collapse of his humeral head. His acromion has really gotten a little thin, which makes you kind of nervous. This is his axillary, which shows he does indeed have some areas of avascular necrosis, and the sphere is not a sphere any longer. Also, the glenoid has become somewhat deformed. You have to worry a little bit about bone loss up superiorly. I personally get CT scans on everybody. This is a patient who has adequate glenoid bone, so you probably don't need a CT scan in this situation. So here he is, can't move his arm. And so this is what we put in. And again, you can notice that there's a little bit of inferior tilt of the base plate on the glenoid. We could only get 3 screws in here, actually 3 peripheral screws. But then here's his motion. Now, you know, his motion is not perfect, but he has no pain. He can reach his mouth and the top of his head without pain. And he's a very happy camper, which is what you want. And but this is a good example of how just changing the tension on the deltoid allows it to actually lift the shoulder. I mean, this guy has essentially no rotator cuff, and his motion is fantastic, and he's very happy. This is a patient who had a failed rotator cuff repair, and you can see that over part of this is from her surgery, but she's just gradually over time worn her greater tuberosity away. Again, you can see she's superiorly subluxed, so you get this sort of double image, you know, in the glenoid. And here's her axillary. Again, she has pretty good glenoid bone, and but if you're in doubt or have any questions, you get a CT scan. So here she is again. She's got that same superior escape kind of thing, where her arm, she just can't get her arm up because it won't go. And it's very painful. So this is, unfortunately, you can tell that she fell and landed on her face just before her 1 year follow-up. So her motions may be a little better than this. Here's again, you notice there's a little inferior tilt on the base plate. And this is early on in the DJO prosthesis. They recommended, as did people in Europe, they originally were cementing all the stems. And these days we press fit everything. She had some trouble with her greater tuberosity. I don't think we broke it off, but again, you want to try to preserve the greater tuberosity because it keeps tension on the deltoid. But anyway, so her motion is not fantastic, but she's pain-free and she's very, very happy. So here's another example of how this operation, how reverses have helped other indications. This is a guy, he's a retired plastic surgeon, and he's had 7 operations on his shoulder. So he had a hemi, and then he got a total, and then that failed. So they put in another hemi, and that time he got a brachial plexopathy. So they went in and they explored his brachial plexus, and they also did a coracoid osteotomy to try to stabilize the shoulder. And so anyway, so here here's his range of motion. You can see he's got tremendous atrophy in the right side, but again, he has superior escape. Partially, there's no real glenoid component. He also had you can see his glenoid somewhat deficient here, so it's not very big. And so anyway, so this is a good indication for reverse. And this is what we did. And this is his motion. It's almost unbelievable. We did manage to crack his humerus here. Actually, we had to split it to get his component out. But at least his tuberosity is involved. And so some people, particularly if you bring the base plate down low, they get this sort of sulcus out here. It's a little unsightly, but it doesn't really affect their function very much in my estimation. So this is a guy who's, in the past, we would have just told him too bad, live with it. And now he's really pretty happy with the result. So there are other indications for reverse. One is, as we mentioned, these fractures. Reverses compared to hemiarthroplasty, all the systematic reviews show that the amount of motion they get is about the same. But the real advantage of a reverse is that patients don't have pain when they move their arm, whereas in hemis, they tend to hurt a lot. So it can be done in patients who have rotator cuff tears, cuff tear arthropathy. Obviously, people have little glenoid bone loss. You can probably get a reverse in a glenoid with bone loss that would not take glenoid components. Fractures we talked about, there are some weird dysplasias or rheumatoid arthritis where the rotator cuff is about gone. Dislocation arthropathies, reverses do great. People have fixed dislocations. Those are rare indications. But again, there's lots of ways you can use a reverse for these varieties of things. So the goal, of course, most of us want a happy patient who doesn't have much pain, and they should have good range of motion and function. This one, of course, is quite happy. And I think it can be accomplished. These operations can be accomplished, I think, depending on your level of expertise, going to courses, scrubbing with people who maybe do them, or particularly if you do any arthroplasties. But it's like anything else. Once you have experience, getting it done gets easier and easier. We did a study that our first 10 of our reverses we did had more complications than our second group of 10. But that was back in 2004 when we were just starting to do these. So I think now the instrumentation's better. The implants are better, and people have, I think, more experience with shoulder surgery now than in the past. So it can be accomplished with practice, and can be a very rewarding procedure. So that's everything you would, as I said at the beginning, everything you would ever need to know about reverse total shoulder arthroplasty. Well, almost everything. And it's been a good pleasure and honor to speak with you. And I guess we have time for a question session here, do we?
Yeah, thank you very much, Professor. It was indeed a wonderful presentation. So if
Okay.
we can share the screen and we have some questions then coming up.
Yeah, so thank you, Dr. McFarland. Really, it was an excellent talk, right from basic to advanced. And I wouldn't be wrong if you could retitle it as Reverse Total Shoulder Arthroplasty for the Dummies. So really, you made it very simple. And also another thing to complement your talk and content is that, you know, although not literally, someone can start doing a reverse total shoulder tomorrow. So it was that elaborate and that much in detail. And thank you very much for giving that time and that information.
Are you guys going to, I got a question for you. Are you guys going to, you're going to put this on your website or something, right? Or
Yeah, so that would be on a website as well as the Indian Arthroscopy Society YouTube channel.
Oh, wow. That's great.
Yeah.
It is already live there in the YouTube
Okay,
channel. And it will be in the archive. It will be in the archive. Somebody can hit it afterwards, even whenever they go to the site. We have got our own site so that anytime it can be hit on, and it can be seen over there. It will be like archived anytime.
Can you put up that case? There was a case which I think, I don't know if Sandeep is able to put up. So how do you deal with the glenoid bone loss, Professor? In the primary arthritic, I mean, do you do a iliacrous graft to augment the glenoid, or how exactly would you do it?
Well, you know, that's a great question, because that's sort of a big issue for, you know, there's easy cases. I showed easy cases. The hard cases are the ones with glenoid bone loss. And, you know, everybody has a little different idea about that sort of thing. I sometimes think I'm not a very good surgeon, because I went through a stage where, well, back in the old days when we had just total shoulders, if you didn't have enough bone, you were screwed. So you had to bone graft. So I tried bone grafting for a while, and, you know, it is not easy to bone graft around a glenoid. And maybe it was because I was younger and whatever, but, you know, bone grafting around the glenoid doesn't really seem to work very well. Particularly, you know, I'm astonished that some people put large allografts in and they claim that it works, because if you notice, all those articles are short-term follow-up. And bone grafting, particularly structural bone grafting, is very difficult. And so, you know, some people now for deficient bone would machine the glenoid to put in
augments.
Put in an augment. You know, again, those don't have a lot of long-term follow-up. People say that they work. I think the first thing is, if somebody has glenoid bone loss, first thing I do is I get a CT scan to look at it. You know, again, 3D CTs where you can kind of spin it around in space doesn't really get it done for me. So I actually get little shoulder scapular models made, and I have a place that makes them for not too much money, $150, but it makes it so you can actually just look at it, you know. And the other thing too is I have really smart guys like Prashant who look at the amount of retroversion and how much humeral head subluxation. And the other thing you can do with these computer programs, I personally am very fortunate in that I have guys like him who can do it. But what you can do is you can medialize, you can template and medialize the glenoid to see how much coverage you have if you remove a certain amount of bone. And so I think that well, my solution for most bone loss, probably 95, 98%, well, probably more like 98% of the patients that I have that have large glenoid bone loss, I'm kind of a little bit of a outlier in that I like to ream them flat. And one of the reasons I can get away with that is that these prostheses that have a large central screw, they don't need a lot of bone. So if I can get a central screw and 3 peripheral screws in, knock on wood, I've not had a lot of failures. So we reported patients in JBJS with 2-year follow-up where we did that strategy where we just medialized. And we had only 1 out of 44 fail or something. And we just finished our 5-year follow-up with that same group. And again, our failure rate at 5 years is 5%. And so probably a vast majority of glenoid deformities, you can, and particularly if you if you're really worried, navigate it or template it, probably 95, 98% of glenoid bone loss, you can just ream it flat and put in an implant and people are happy. The people say that there's 3 problems with that. One is that number 1, you medialize. First off, you remove a lot of bone. It doesn't matter what you put in there. If it fails, there's not much bone left, because I do some revisions of reverses, and once they start moving around, the bone just, the screws, it's the same as revising a total shoulder with the old keels. You end up with a big hole. And so I don't buy that so much. The other is that it theoretically decreases the range of motion, and there's really not, even though those are biomechanical studies, there are no real biologic studies that indicate that people have worse motion if you medialize.
Somebody will actually send us a CT scan. So if Sandeep, you can just show CT to just 3-4 films to Professor McFarland and see
Yes.
what is the, Sandeep, you can share. So, Professor, these are CT films of 3D CT films of a glenoid bone loss, which is going right till the coracoid process. That's a rheumatoid shoulder.
Yep.
We have just got these 4 pictures, not more than that. So would you actually go medialize till the base of the coracoid, or would you actually augment it? So that was the question which the delegate had asked.
Frankel talks about putting, medializing and putting a screw through the base of the scapular spine here. He calls
Can
it.
I unshare it?
Yeah, you unshare it, please. Yeah, we can then talk. Yeah. Yes, sir.
Anyway, so I would get out the software and model that and see if I went real medial, how much bone was left. The thing that's really interesting is, we don't have many that we've done, but there are several companies now that make custom glenoids, and so you don't really even have to worry about.
But that's
how much,
true. But in our case, we don't have a customized glenoid available. So would you? Again, I mean, in a cuff arthropathy, you still have a humeral head from where you can take a slice of bone and then put it onto the glenoid side. Would you do that?
Like a bio-RSA.
Like a bio-RSA?
I don't have a lot of experience with that, because like I said, fortunately, in the days before we had any kind of augments or bone, I don't know, bone grafting, I just have not had a lot of good results with bone grafting.
Yeah, IBS,
So a lot of people show all these papers that 2-year follow-up with bone grafting, and everybody's done fantastic. I'm just not convinced. And so I would ream this medially as much as humanly possible to get it flat. And if I modeled it and that wasn't humanly possible, then I would probably under duress bone graft it and pray that it stayed put. The final thing, and obviously the solution I would have would be to have a custom implant made. The trouble though, as you know, is reverses are kind of expensive and the custom implants are really expensive. And so, somebody's you have to be the top 1% to get the, to get the custom. So yeah, I think in that situation, I would bone graft it as a result, do not have a lot of experience with using bevels. The thing that's interesting about the augmented components is most of those studies, the average amount of retroversion that they're repairing is like 9 to 15%. And, you know, 15% is nothing. I mean, you can ream a glenoid with 15% down and put in a reverse, and they're going to do fine most of the time.
Dr. McFarland, I have a couple of plan cases for bone loss on the blueprint. Do you want to share that with everyone?
Yeah, sure. You can share it.
So yeah, that's a customized which you're going to make an implant. Okay.
That's what software the French are also using. Jill Wall's
Right.
Pascal Boileau and team.
Right.
Yeah.
Right. Well, see, the beauty of this is that you, like, say, if you medialize this guy right here, it looks like you're taking a fair amount of bone off.
Yeah.
But I mean, this patient's glenoid's fairly medialized, but you know, you can ream it flat like this, and you're going to get how much coverage do you get down there?
It's about 91%.
Yeah, if you ream it flat, you get about 90%. And so in this situation, I would probably the posterior inferior screw, you probably couldn't get that in. I don't worry about that. You know, this, again, the central screw prostheses, the beauty of those is you just don't need a lot of bone. That may be the case with the pegged components. My bias against peg components is because early on with the Tourniers, the Vermont Tournier prostheses early on in the mid 2000s, you know, you would ream they didn't have a lot of instrumentation. So some of it was kind of, you know, done by hand. And a lot of times you'd put the central peg in and the thing would be rocking around. And so then you're purely relying on peripheral screws for the fixation. Whereas these days, most of the designs allow for central peg fixation that's pretty secure, or the central peg's augmented with a screw or whatever. But the central screw type designs, they are like fantastic.
Yeah, and also not to forget that if you do a bio RSA type, you need a longer peg. Otherwise, you know, it won't have a hole. So you need really different implants if we were to bone graft the glenoid.
Yeah, you know, it's interesting that you know, I haven't unfortunately asked actually I've asked a couple guys, but you know that they talk about using a longer central peg.
Correct.
And you know, the last thing I think you want to do is to stick a big hole in the medial aspect of the glenoid.
Correct.
So putting a central peg all the way through the central part of the glenoid doesn't make any sense to me. I'm surprised that there's any glenoid left. And certainly if you ever have to revise that, then you're really screwed. So these 6.5 screws that are central, they're fantastic. And, you know,
Yes,
I've been...
There is a
Prof,
question
yes.
when to do a 135 or a 155? I mean, the head, 135 or 155? So
we actually looked at our experience and with that, and so the first ones I did were all 155s, and then I switched to DJO, which are 135s, and the dislocation rate went from 8 to 9% to less than 1%.
okay.
So, you know, just that change alone, I think really made the difference. So even Walsh recently, JSES has this thing where they ask leaders in the field what they've learned over the years or whatever. And so even Walsh in his what I've learned thing said, well, you know, I've kind of lost the argument about medialization and about the head neck angle, because the dislocation rate is just so much higher with the more horizontal head neck angle, the 155s. It's like not even close. So you know, I went from dealing with these dislocations all the time to none. I mean, I almost never get a dislocation anymore. And so it's probably, it's probably a combination of the more, well, it's not more lateral, it's less medial actually, but the more lateralized spheres sort of bring it a little further away from the scapular rim and also lateralize it. So I think that one of the big issues these days is, the big thing is whether you should use an inlay tray or an onlay tray. And so, I think a lot of these sort of discussions we've gotten to the point where, some of these discussions are splitting hairs. My personal feeling is that, all these biomechanical models, there's no soft tissue, right? So we, unfortunately, being a bad surgeon, I just medialized everybody from the get-go. And, you see those patients and they're happy because they have no pain and they've got good enough function that they're happy and they don't dislocate. And, so it's kind of hard to say, oh, well, I'm going to get a little more external rotation and use an inlay, I think they don't really care. They're just happy because they don't have pain, So, I think, fortunately, there's a lot of slop in the shoulders, and so it makes a bad surgeon look good.
Okay, Prof, I've got a question. Okay, Shreyash, can I go?
Please go ahead. Yeah, please.
Okay, the thing is that because of the inferior notching, we sometimes put the base plate bit downstairs, and also in inferior tilt this way, because we have been taught that way, that it has to be like a 6 o'clock. It can overhang the plate sometimes, or you can do the inferior tilt. What is your tricks on that to avoid the notching on the scapula?
Well, there's really basically three questions there. One is, how do you avoid notching?
Yeah.
The other is inferior tilt. Now the inferior, that's the easiest question. The third is bringing the sphere down. And they're all kind of related. The inferior tilt thing, again, it's biomechanical study and saw bones or something. And somebody recently did a study looking at a clinical study looking at it, I think, and found no difference in clinical result whether they had some inferior tilt or whether they were neutral. But what they did find was that if you have superior tilt, right, like I said earlier about varus in the knee, that's bad. So you do not want superior tilt. So the shoulder you have to worry about is the one that I showed several pictures of, where the upper half is kind of gone. In those patients, you have to remove more lower bone to at least get it to neutral. So I don't think inferior tilt is quite an issue anymore, because inferior tilt was designed to decrease base plate failure, and almost nobody has base plate failures anymore. So at least in my practice. The second thing was bringing the sphere down, bringing it down. I think there's been sort of a move towards doing less of that. When I actually, have that little base plate guide. I usually try to make it so that the inferior edge of the sphere lands right on the edge of the calcar there. So in other words, I don't like a lot of overhang. I think the prostheses that are designed, I just don't think that you need a lot of overhang inferiorly to prevent notching, because the notching hasn't really proven to be a terrible problem. There's a lot of it, but fortunately people are failing wholesale because they've got some notching. So the trend has been away from a lot of inferior inferior translation of the sphere to a more central position. And I think people do okay with that. And the one thing that I think has been shown is that if you bring the sphere down a lot, it puts a lot of tension on the acromion and the spine. So there's more acromial fractures. So I think to prevent that, the move is towards putting the sphere a little more superior and not bringing it down so far. I usually, the other people too, a lot of people get kind of hung up on how putting a bigger sphere in, and I don't think that's necessary either. If your sphere overhangs 2 millimeters all the way around, it's just too big, and so I don't, I try to keep it fairly. I don't go real high and make it central. I don't think you want exposed bone on the inferior part. But going to the 135s has also decreased the notching significantly. When we looked at ours, when we looked at our Tourniers, the notching at 2 years was 80%, and the notching with a more lateralized glenoid sphere was 8%, 9%. And I think some subsequent studies showed maybe as high as 20%, but nowhere near as bad as with the 155s. So I think a more lateralized sphere and a 135 head neck angle, I think you're pretty good to go.
Harpreet, you have a question. You wanted to talk to.
Oh my God! Look at that.
Welcome, Harpreet. Welcome.
Hey,
Welcome to the forum.
Whose beard is more white?
Yeah, very nice to have you in COVID beard. Very nice. A long time. I just had a question on this in fractures when we do reverse. How do you get on with your GT, and do you stitch back the subscap in those cases? GT and subscap in fracture cases, reverse shoulder?
Well, fractures, most of the fractures that you're going to fix, the lesser tuberosity is off anyway.
Yeah.
And so I always try to maintain the bone tendon junction. So you thin out the lesser tuberosity, but you don't remove it. And so, yeah, in those cases, when you put the tuberosity back, the best way to do it is to sew front to back and pull the two tuberosities around the prosthesis. I don't use fracture prostheses much because not that I ever have had to take any out, but I can't imagine trying to take out a bone, taking a fracture prosthesis out that has bone ingrown through the proximal part of it. I mean, you'd have to destroy the humerus. But the other is, oddly enough, is that just the regular stems. I press fit a regular stem and put the tuberosities back around like this with bone graft underneath, and they do okay. Again, I think if there is no lesser tuberosity or the subscap is torn with a fracture, I don't worry about it, except that it makes it harder to fix the greater tuberosity. The one thing you do want is the greater tuberosity, because once you lose external rotation, you're screwed. So maintaining the greater tuberosity around the outside, around the lateral side, and putting a half to pull it around, put a stitch through to pull it around. I also am not real fond, only because it's a lot of futzing around, is putting sutures around the implant.
So along in the same question, so isn't it the reason why in these comminuted 4-part fractures, especially in the elderly, when we go on to do the reverse, the functional outcomes are a little inferior compared to cuff tear arthropathy patients? So could that be a reason?
Absolutely, but that's not because of the reverse. That's because of the nature of the injury. It doesn't matter in a 70-year-old. It doesn't matter if you ORF, if you HEMIARTHROPLASTY, or you do a reverse. They all get about the same amount of range of motion. The issue is, with ORIF, you're going to get a huge failure rate probably. The second is with HEMIARTHROPLASTY, the tuberosities disappear and you get superior subluxation and they hurt all the time. And reverses, the great thing about reverses is they don't hurt. They do tend to get relatively good range of motion. And so the biggest advantage of reverses is they don't have the pain that they have with a hemi, but none of them get really great range of motion because there's just so much scar.
Correct.
And you maybe can move them a little earlier with the reverse, but even if you do, they still just scar in like nobody's business. It's really So I think the scar formation is probably the bigger problem for reverses.
Sure. While we're there, regards the subscap, I just have one more question related to that. So obviously I understand that literature says that there is no real difference whether or not you repair the subscap, but isn't the issue of instability and maybe superior subluxation a problem in extension of the arm? Because once the arm goes back beyond the, the axis of the thorax, then there is a risk of anterior superior escape in the absence of the subscap repair. And this is especially encountered in these elderly 4-part fractures where, the lesser tuberosity is very wafer thin and the muscle may have been of so poor quality or tone. So what are your views on that?
Well, no, I think you're right. I think that's exactly right for ORIF and for hemiarthroplasty. But the beauty of a reverse is you don't need your subscap. So who cares? But in most of the fractures, the subscap, that piece is getting it back is actually easy, in reverses, the beauty of reverses is your rotator cuff can essentially fail and they still have pain relief and pretty good motion. Whereas with a hemi, if the rotator cuff fails, they get crappy motion, shitty motion, and it hurts. So the reverses are the one thing that's reverses has done. It's made the result in terms of pain relief, at least, more predictable. Range of motion is still an issue even with reverses, but because of the nature of the injury,
Prashant, you had a question.
Yeah, Dr. McFarland, initial part of my career, I worked in India, and now I'm seeing all these great patients in Hopkins. So I think one of the striking differences in Indian patients or South Asian patients as compared to the US patients is osteoporosis. Many of the times we had to deal with paper thin bones, and even when we are doing arthroplasty amongst Indian patients, that is the only surgery they would have in the whole life. So if you have to get it right at the first time, and that's really the onus is on the doctor. So looking at this background of South Asian patients and everything, when we have osteoporosis, is that a part of your patient selection criteria of your algorithm when you're choosing the patients? Number one. Number two, if you're doing an arthroplasty in osteoporotic patients, which kind of implant selection would you have? Like how many minimum number of screws in the glenoid, or whether to select an cemented humerus or uncemented one? So which kind of precautions we should take for optimum results in osteoporotic patients?
Well, the only population we have that has that kind of osteoporosis generally are the rheumatoid patients and or with other rheumatologic diseases. And I think when we looked at our base plate loosenings, we didn't have huge numbers because even rheumatoids anymore are treated so successfully with drugs that we don't do arthroplasties in those people like we used to. And anyway, so one of the risk factors was rheumatoid arthritis for base plate loosening. So it is absolutely a concern in somebody who has osteoporosis. I would still use the same kind of implant and shoot to get as many screws as possible. Probably the other trouble with a lot of those patients is they're very small, so you want a base plate. You might want to use a system that has a smaller base plate. And there aren't many systems out there that have a 25 millimeter base plate. Almost all of them are 28 or some even larger.
32, that's what we have in India, 32.
Yeah, and the Striker's a 28, I can't remember, maybe Biomed or somebody, they have a 25. I did a live surgery in Thailand, and I think they had a 20. I can't remember. I think they had a 25, and even a 25, you can only get 3 peripheral screws in this woman. I mean, she was that small, and so. I would try to get as many screws as possible. I think 3 screws is peripheral screws I'm talking about would be optimal. The thing that's interesting is, the Zimmer component has only a superior and inferior screw. And I've always wondered how in the world, you know, that that survives, but they do fine. You know, I don't get it. So you probably can get by with 2 screws in the population. One thing I do definitely though is I don't let them move early because you know most of those patients, I don't think bone ingrowth into the base plate happens very much, and the stabilization in most of these patients is because the bone stabilizes in the screw threads. So I prefer a system like the ones I've mentioned that have a central screw. But the one thing you have to be careful about is that you want a good bite in the central screw. If you put it in and I call them spinners, you know, if the base plate is spinning around, then you got a problem. And that patient, I would probably not let them move for 6 weeks, you know, just hold them down and hopefully prevent failure. I don't, you know, we don't have much experience here with doing DEXA scans on everybody or anything like that. So
if you had to do a reverse on a patient with Parkinson's, say a 4-part complex fractures, what would be some different from the routine that you would do?
Well, you know, Parkinson's patients, there's 2 problems with Parkinson's patients. One is they fall a lot. And the second is they shake. And so I always tell my patients that, you know, the base plate's like putting a screw in that drywall. You know, if you start moving it around like this, it's going to get loose. And that unfortunately is what happens to some Parkinson's patients. I had one guy, after we put it in, he sort of got this athetoid kind of thing, you know, and it was really remarkable that the thing fell out in about 3 months, and there was heterotopic bone everywhere. It was a disaster, and he didn't have the athetoid. His Parkinson's just got really worse, you know. So Parkinson's patients can shake things loose. So you got to be real careful about how bad their Parkinson's is when you treat them. But I put them in patients with Parkinson's because they're miserable and they're very happy. And some of them may get loose later. It's just a chance you take. Unfortunately, he's the only one that's been a real disaster. You know, most of them, they get really good pain relief and they're very happy and it's not a problem. But there are the ones who then fall, and I'm still sort of waiting on short stem results to go there, or stemless or anything. Usually their bone is so bad, a stemless or a short stem isn't going to work anyway. So maybe concern for proximal humerus or fractures, maybe a short stem. But you know that the trouble is there's studies that show that the fracture rate for short stems is about the same as it is for long stems. So they can still fall and break it. So yeah, Parkinson's patients, we're big in the States, we're big on informed consent, right? And so I just let them know that, you know, if they fall, there's no guarantees.
So does putting in a large glenosphere help compared to the regular size glenosphere?
You know, I think most of the studies show that the size of the glenosphere in terms of instability doesn't make any difference.
Okay. Okay, thank you.
I've got a question that nowadays we are many times we have listening that when we use the hemi stem, then we used to go for the platform stem. What stem you choose for your hemis?
Hemi versus which?
No, sometimes we have been dealing with the platform stem for the hemi so that we can go with the total or reverse afterwards. What is your take on that, and what stem do you use for your hemis?
You're talking about hemiarthroplasty for fracture, right?
Yeah.
Well, you know, it's interesting that that it's when you know, the sort of 3rd or 4th generation proximal humerus component came out. Walsh and the guys in France, they came out with a fracture stem, right? Yes. And they, after 3 or 5 years, compared the results of the fracture stem to a regular stem, and there was absolutely no difference in clinical result in fractures, hemiarthroplasty for fractures. So the point being is that that the idea behind the fracture stem was that you get better tuberosity fixation or whatever, and ends up that whatever it is that happens to the tuberosities can happen whether you use a fracture stem or not. And so the fracture stems didn't really ever prove to be an improvement clinically on compared to hemis for fractures. My personal bias is that, you know, for some reason the body is, I think that when you have a tendon bone interface, you know, if the muscle and the tendon don't have exactly right tension, for some reason the bone just disappears, right? I mean, somehow there's some feedback there that if you don't get it just right, the tuberosity is going to resorb or the tendon's going to fail or something. And so consequently, the fracture stems didn't really change that mystical biology. So the amount of tuberosity resorption with fracture stems was just as bad as it was with standard hemis. So
I have another question about painful shoulder arthroplasty. And many times when we do all these surgeries, but patient still has persistent pain. So would you recommend giving steroid injections in an arthroplasty, or that's something which is too dangerous? Or
well, you know, pain after a reverse, I'm assuming you're talking about pain after reverse. You know, the first thing you have to rule out is an acromial stress fracture or a spine stress fracture. If they obviously have a lot of pain, you have to rule out infection. And so, you know, like any arthroplasty, the #1 cause of bad pain is first top 3 causes are infection, infection, infection. Then you worry about stress fractures, and in a total shoulder, you obviously worry about rotator cuff pathology. Fortunately, metal reduction MRIs are fantastic for making that diagnosis. But usually, if their cuff's gone, you can tell on exam. Usually, for the ones after that are kind of painful, and their workup for infection is negative, I'm very hesitant to inject steroids into total shoulders.
Yes, never. I've also never injected any shoulder.
Yeah, I don't like to do that. I'll give them oral steroids, you know, those dose packs and things, and sometimes, even more rarely, the posterior screw is up against the suprascapular nerve or something, and so you can get an EMG to sort of confirm that or not. But you're right. There's probably, again, that's a topic. It's a good topic for you, Prashad. We can look these up and figure it out. But there is that small percentage of patients. It's like total knees, right? There's like the small percentage of total knees. They're hurt all the time. They're not better, and you know, you can't figure it out.
Great.
And the beauty of we've been kind of fortunate, you know, at Hopkins. We have metal reduction MRI of the shoulder, and we've got guys who are experts on that, and you know, and so we do these Mars MRIs on these patients, and there's nothing, you know, but yet they're miserable, and it's like a total mystery. So that's a topic, actually. That's a subject I've wanted to study, is to take all our reverses and find the ones who have intractable pain afterwards, and try to figure out what they have in common. Unfortunately, and I don't know how it is in India, but you know, there's still some patients who have secondary gain, like workman's comp or whatever. I've had several patients, we couldn't figure out their pain. They finally settled, and you know, they came in for their 3-year follow-up or whatever, and they go, oh, look, you know, my pain got better. so maybe the settlement helped, but then again, you kind of hate to blame that. You know, there's still that small, tiny minority, maybe 1 or 2% that just don't get better, and it's weird.
Are there group of patients where you alter the offset. They have a deltoid insertional pain because you make it more longer and tighter sometimes.
No, they no, they don't. That doesn't bother them, but they sure do bitch about their shoulder doesn't look right, you know. And some women complain because their bra strap won't stay on. so no, not usually. You know, not usually.
There's one question on the chat about what's the role of robotics in RSA in 2020?
What's the role of what?
Robotics.
Oh, robotics. You probably, you know, you probably don't need it most of the time, you know. And I think if you get a CT scan and unless they've got huge amounts of bone loss, you know, you don't really need to do it. And the other, you know, it'd be kind of nice if it didn't cost so much. You know, like even in the States, I can't rationalize 500, even $1,000, or, you know, seriously, you go to the company and say, oh, well, $1,000 to do the navigation, that's kind of expensive. And have a guide made, you know, and that's gonna, you know, the guides have been shown to have like, they're off like 1 millimeter or 2, and by 2 or 3 degrees or 4 degrees. And hell, you can do that just shooting it, you know. And it's sort of like, again, it's sort of like total knees, right? Or navigation for total knees. You can navigate and you can make it really accurate, but in the final analysis, the clinical result's the same. So a lot of it is, I think the only time you need navigation is for people with big bone loss and or where you're worried that they have too much bone loss. But otherwise, I don't think you need it,
sure.
Frankly.
And there's no talk on shoulders complete without a question on rehab. And my question to you is, how much importance do you pay in terms of your patient undergoing a good rehab, especially the cuff compensation exercises? Because in my practice, I've seen a group of patients, I've done the same surgery, the same prosthesis, they are really doing well. And a small percentage of patients don't have quite the same kind of forward elevation. So, you know, and when you ask them closely, the reason is that they've not done the rehab properly. So what are your thoughts and what is your experience in this?
Well, a couple things. One is when I first started doing these, I was pretty nervous. So I didn't want anybody shaking the screws, right? And some of the times, because I was using a central peg kind of prosthesis where like I said earlier, where I was relying on the peripheral screws for fixation, I wasn't about to let anybody move those guys. And so, so I started out not doing any therapy at all. You know, I think one thing I do think is really important is patients need to move their finger, wrist, and elbow right away. Because if you got a bad shoulder, last thing you need is a stiff elbow. And so there've been a couple patients whose elbows got stiff, and it's a disaster, you know, because they just can't get things done. And so I think I start that immediately. And if I'm worried at all, I don't let them do pendulums for the first week or two, but we try to start those right away. But anyway, so early on, I was worried that if a therapist got a hold of somebody and started cranking on their arm, they would torque on the sphere and the base plate and pull the screws out or get them loose or whatever. So for probably the first 2 years or so, or 3, I didn't send anybody to therapy at all, period. And you know what? By 3 months, they all had like fantastic motion. They were all pretty much happy. I also still to this day don't let people do internal rotation up their back because I just think it puts a lot of torque on the screws and things. And I let them start doing internal rotation up their back at 3 months. And most of them get real good motion up their back. Oddly enough, it's kind of unpredictable who gets good motion up their back and who doesn't. But in terms of forward elevation and rotation, external rotation, ability to reach the top of their head, almost everybody gets that back. So I in fact don't do physical. I don't have my patients do physical therapy as a result of that. And the only time I'll do physical therapy is if at 4 to 6 month range, they're still stiff and still complaining. I might give them a Medrol dose pack or something. But I don't like people cranking on the screws. You know, the trouble with therapists is, you know, their idea of range of motion is torquing on somebody. Or the other thing they do is they want everybody to be strong. And the best thing to do with these patients is just let them cool off. I tell them, look, you got the rest of your life to get strong. Don't be doing a bunch of weights and tubings and crap like that. It just aggravates their shoulders. And oddly enough, they seem to do pretty well. Now, the second thing I was going to say is there has just recently been a study published where they sort of did that. They had patients do rehab and patients not do rehab, and they all had the same result. So, you know, I think you can get by without rehabbing these patients. I've had a few that just couldn't seem to get it done, and they, you know, it's the judgment call. You know, we all have patients, some who kind of get it and some don't, and the ones that don't, they end up with rehab. But I have to say, I think probably percentage wise of my patients who go to rehab, it's 1%.
That's great.
Any other questions, Swarnendu, IPS?
No, I think we have
Okay.
already done 1.5 hours.
Yeah, great.
We tried 2 hours. Yeah.
Okay.
So it was a great lecture, sir.
Yes.
Really, it was a nice listening to you, and yet really we are fortunate that you have agreed, and it is a great pleasure that Shreyash has talked to you, and you have agreed for the forum, and it will be archived in our IAS website. Anybody can hit that, and anybody any time can see that.
Great.
Great. It's always a pleasure for the Indian Arthroscopy Society. So thank you, Dr. McFarland, and thank you, Prashant. It's been a wonderful 1 hour, 1.5 hour session. I really thank you for spending the time and agreeing to participate. And we look forward to connecting at some point in the future.
Great. Thank you very much. And I want to thank Harpreet for wearing that hat.
Yeah, especially we had to get out.
Thank you.
Take care and goodbye from here.
Bye. Thank
Thanks. It's been my pleasure. Thanks so much.
Thank you, sir.
Take care. Take care.
Bye.
Right. Bye-bye.
Bye-bye.
IPS, sir.
Yeah, so,
Okay.
Thank you very much for tuning in. We have our next webinar, which is essentially a basic arthroscopy series, number 3, where Dr. B.B. Bhasin has been kind enough to give a lecture on arthroscopic equipments, how to take care of these equipments, and for a beginner, how to develop the skills of triangulation. And it would be really a great talk by Dr. Bhasin, seeing his experience in arthroscopy for around 30 years now. So we should tune in on Tuesday, which would be at 7 p.m. on Tuesday on IAS YouTube channel to have one-to-one chat with Dr. Bhasin on the basic arthroscopy technique. Till then, thank you very much and have